Bismillahirrahmanirrahim. In this video we are going to discuss the mechanism of action of methotrexate and how in the body it produces the folic acid deficiency. Before the development of methotrexate in 1951, a folic acid analog used to be given for the purpose of treatment in rheumatoid arthritis, and it is known as the aminoterin. In 1972, well versatile, more decorated form of aminoterin was introduced. This is known as the methotrexate, which in these days is well known by name methotrexate. Now question arises, if methotrexate is the folic acid antagonist, then how it is known as the analog of the folic acid? Confused? Methotrexate is the analog of folic acid. Really confused? Folic acid is also known as the vitamin B9. If you look at the word folic acid, there are the 4 letters in acid and 5 letters in folic. 4 plus 5 is equal to 9. Very easy to remember. Folic acid is also known as the vitamin B9. You don't need to be confused. I am clearing your concept. But before we go into the detailed mechanism of action of methotrexate, I want to tell you that there are the uses of methotrexate in the medical science. In the skin, it is used in many conditions, but psoriasis is one of the most common. In the gastrointestinal, it is used in the inflammatory bowel disease such as ulcerative colitis and the Crohn's disease. It is also used as the chemotherapeutic agent in many cancers such as leukemias, breast, head, neck and lung cancer, and many other cancers as well. For the rheumatological purposes, it is used in rheumatoid arthritis, SLE, dermatomyositis, systemic sclerosis, and in many other conditions as well. For the gynecological purpose, it is used in the ectopic pregnancy, trophoblastic neoplasms, and in the neurological conditions, it is well known for the multiple sclerosis. And for the orthopedic purpose, it can be used in the osteosarcoma. Now, before we discuss the mechanism of action of methotrexate, let's see, for example, this is the structure of the cell, and it is the cell membrane. On the cell membrane, the receptors are present. These are the glycoproteins receptors. In this protein, the most common amino acid, the most abundant amino acid present is cysteine. Therefore, these glycoprotein receptors are cysteine rich and they are the folic acid receptors. There are 3 folic acid receptors, alpha, beta and gamma. When the high dose is given, it is taken up by these receptors and driven into cell, where it acts on the enzyme dihydrofolic acid reductase. Dihydrofolic acid is formed from the folic acid by another enzyme, but we are not discussing that. But dihydrofolic acid is converted into more active folic acid, and that is tetrahydrofolic acid. This tetrahydrofolic acid undergoes by the various series of the enzymes, and it is responsible for the nucleic acid formation, that is DNA and RNA and other enzymes of the body, and the methionine, which ultimately
methotrexate is known as the folic acid analog because, like that of the folic acid, it is specialized to bind with its receptors. But unlike that of the folic acid, whenever it is taken up by these receptors inside the cell, it does not act like that of the folic acid, and hence the folic acid is not taken up by the cells. It is excreted into urine because it is a water soluble vitamin. It is also known as the B9 vitamin, and whatever the amount of the folic acid if taken inside the cell, it is not let to be converted into its active form, that is the tetrahydrofolic acid. Hence, methotrexate causes the folic acid deficiency because it causes the excretion of folic acid into urine. When the methotrexate is given at the low doses, it not only inhibits the dihydrofolic acid reductase enzyme to some extent, but also it is converted inside the cell into the polyglutamate. This polyglutamate is specialized to inhibit the other enzymes inside the cell as well, and among them one of the most common is the AICAR, that is amino imidazole 4 carboxamide ribonucleotide transformase. The ultimate end product of the methotrexate inside the cell is the adenosine, and this enzyme is specialized to convert the adenosine into the inosine. So when this enzyme is inhibited, the adenosine is not converted into inosine. Hence, there is the intracellular accumulation of adenosine, and this is thrown out of the cell through the transporters, where it acts as the anti-inflammatory. It downregulates the receptors of interleukin 1, interleukin 6, and the tumor necrosis factor alpha on the neutrophils, macrophages, and the T cells. Hence, it acts as the anti-inflammatory. Methotrexate acts as the anti-inflammatory at the low doses. Now, if someone is asking you the dihydrofolic acid reductase inhibition mechanism is understandable in the cancers, then how the methotrexate is also being given for the rheumatoid arthritis, which is not a cancer, SLE, which is not a cancer, psoriasis, which is not a cancer, ulcerative colitis or the Crohn's disease, which is not a cancer, then why it is given? It is given in these conditions at the low doses, because at the low doses the methotrexate through the inosine mechanism acts like the anti-inflammatory agent. So now if someone is asking you that what is the mechanism of action of methotrexate in the rheumatoid arthritis, you will clearly answer that there are the various mechanism, but among them the most familiar, most common is the adenosine hypothesis mechanism. I hope now your question regarding how folic acid causes the how actually methotrexate causes the folic acid deficiency and what is mechanism of action of methotrexate in the rheumatoid arthritis, how it acts, is a little bit clear now. I will form more videos on the methotrexate, the dosage of methotrexate, how it is adjusted, how it is monitored, and if the patient is developing side effects secondary to oral use of methotrexate, then if the injection parental usage of the methotrexate is advised, then how it is correlated with the oral doses of methotrexate. More videos will be formed on it. Thank you.